2020 is definitely a year we will not forget, and COVID-19 touches all of us. We had, most of us, a period of hard work and stress, and maybe it touched some of your family members, friends, or colleagues with disease. And if that's the case, we send you all best and warm positive waves to you and doing this online this time. COVID-19 is a difficult topic because a lot of things are not known yet. But we would like to use the COVID-19 topic and see how this disease affected the child, and not only pure looking to anesthesia, but looking to the entire perioperative period. For doing this, we use the help, and I'm really grateful to have some colleagues, and they are well-known specialists in their fields, to talk about different topics, looking at pediatrics, intensive care, and psychiatric topics also. So you have seen the program, and there are lectures with question about 30 minutes, so it will not last too much. You will have some times to use your Saturday with your family and friends. For the BAPA members, don't forget the General Assembly, which will start just after this webinar around 10 of 30 past 11. So I give now immediately the word to my two friends and colleagues, moderator, and they will explain you how we can work with this webinar Zoom session and introduce the speakers.
Thank you very much, Thierry. Good morning, everybody, and welcome to the virtual webinar seminar on pediatric COVID-19 organized by BAPA today. And thank you for being with us. My name is Nadia Najafi. I'm currently at the University Hospital of Brussels, where I serve as a pediatric anesthesiologist. I will be hosting this webinar session today together with my colleague and friend Joris Wundelings. And before we begin, I would like to remind you that we are recording today's session, so you can go back and refer to them when it's convenient to you. And also that we won't take questions live, but at the end of each session, we will go through these questions that were submitted via the chat exchange provided to you by this hospital. You are very much encouraged to submit your questions through the system. And again, we will get back to you and to as many questions we can at the end of each session. Please switch off your microphone during the presentations. Today, we are going to talk about the care of the pediatric patients with COVID-19 with the intention to increase the overall capability of the healthcare system in order to safely and effectively manage children with suspected or confirmed COVID-19 infection. I'm going to turn today's presentation over to the real experts on this matter. And now I'm very pleased to welcome you, our first speaker, Professor Dimitri van der Linden. Professor Dimitri van der Linden is a pediatric infectiologist who currently works at University Hospital of Saint-Luc in Brussels. He is the representative of the Belgian pediatric COVID-19 for the French-speaking part of Belgium. He will be sharing with us his top expertise about epidemiology, clinic, and transmission of COVID-19 in children. Professor van der Linden, it's so good to have you here with us today, and thank you very much for joining us.
Thank you very much for the nice introduction. So since the beginning of the pandemic, we were quickly reassured about children and COVID. We heard from our Chinese colleagues first, and then from Italy, We had webinars with our colleagues in Italy telling us that children were not a problem. There were few admitted children. And
Professor van der Linden, I'm sorry.
yes.
Can you share your slides with us, please?
It's not shared. Sorry about that.
Thank you.
Do you see the is it correct now?
Yes.
Okay. So and quickly after the beginning of the pandemic, we had early contact with our colleagues, and in March, end of March, spontaneously pediatricians in Belgium moved to gather together and created the pediatric task force to share knowledge about COVID. So in Italy, for the example, from the beginning, they were over-testing children, and they were testing widely children, and they realized that there were few children compared to adults who were tested positive, and that mainly a positive child was within a household with an adult infected patient. So, sorry, my screen is not going through. Okay. Do you see the next slide? Yes?
Yes.
Okay.
I can see your slides. Thank you.
Okay, thank you. So first of all, I would try to give a few words about global epidemiology of COVID in children. So the first systemic review showed that globally there were between 1 to 5% of reported cases were children, and children less than 1 year, less than 10 years of age represented less than 1%. And those numbers were confirmed with different other studies in China, UK, and US, with the same kind of number between, between 1 to 5% of all cases. In Belgium, we have we are lucky. We have Cienzano who do a very good prospective surveillance of cases. And as you can see in this slide, in Belgium, 1.8% of tested children are positive, compared to 6.3% of adults. In total, in Belgium, children represented 3% of all infections. On the graph, you can see that the percentage of testing vary according to age, with less than 1 year old children and adolescents having higher testing rate than the other age groups. So we can say that children and adolescents are less often infected than adults. We don't really know exactly why, but there are some literature about the fact that children can get cross-reactive immunity against other viruses, protecting them against SARS-CoV-2. Also, some papers showing that children have a less important expression of some receptor to the virus, like ACE2 receptor expression, that could explain the fact that the rate of infection is also less important. So what about the clinics? We all have the same experience in Belgium, working in all the hospitals, but also our colleagues working in private, that children with COVID are mainly post-symptomatic with mild or moderate symptoms. Some of them are asymptomatic, and in China, the first report gave numbers up to 20% of children who are asymptomatic. When they are symptomatic, most of the time they present the similar symptoms as other respiratory tract infection like colds or flu, etc., RSV. However, there has been a few reports on hospitalization of sick patients, and the most important paper recently was published by Götzinger et al. So mainly the pediatric TB net in Europe, mainly pneumologists and pediatric infectious disease consultants working in tertiary or quaternary hospitals. And you can see that in this paper, most of the patients were hospitalized, which is a bias, of course, because they reported the more sick patient with 4 deaths during the peak period. So in April 2020, 582 patients with a median age of 5 years. A quarter of them had pre-existing diseases. And so 62% were admitted to the hospital, with 48, so 8% in PQ, with 25 patients requiring mechanical ventilation, 3% some hemodynamic support. And the risk factor in this study to be admitted to PQ was age less than 1, male sex, and having comorbidities and lower respiratory tract infection signs at the time of presentation. So this represents important data for sure, but we have to say that it's mainly data coming from tertiary and quaternary specialized hospitals. In Belgium, again, a collaboration work with Cienzano recently submitted, show that during the period between the 14th of March to the 28th of June, 1.6% of hospitalized patients were children. So it represents 262 patients out of 17,000 total patients. During this period, there were no deaths reported in the hospital, but as you might know, there were one child, 12 years old girl, who died prior to admission to the hospital at that time. You can see that a high number of them were less than 1 year old, probably due to the more caution attitude concerning young infants who were more easily hospitalized for surveillance, mainly the less than 3 months old children who are febrile. There were 7 patients who were admitted to PQ, representing 3.4%. And in this paper, the risk factor for being for having a serious event like PQ admission or ARDS was the age more than 1 year of age. It's also important to know that, this age can be biased by the fact that, in fact, a high number of patients were admitted less than 1 year with mild disease. It's very important to note that there is no report of pediatric inflammatory multisystem syndromes. And later this morning, Jeff Williams will tell you more about this syndrome that we reported in the era of COVID-19 in children. So we can say that children and adolescents are less severely affected than adults, and less often admitted to the hospital and less often affected. I just want to say, to give a note, you may wonder why I put this image, this picture, just to tell you that we have to be careful about tunnel diagnosis in the era of COVID. And we reported a case of a 13-year-old girl with Down syndrome presenting with the typical picture of COVID-19, lymphopenia, inflammatory syndrome, and all the respiratory picture, who was diagnosed with Mycoplasma pneumoniae infection. More recently, we admitted a child with 13-year-old child with immunosuppression, chronic corticosteroids for NMDA and encephalitis, presenting with also the quite typical COVID-19 symptoms, with also a mother who was sick, but PCR negative mother, and at the end all PCR were negative, and the child was diagnosed with PCP, pneumocystis jirovecii pneumonia. So we just need to be careful that in the era of COVID-19, other diagnoses, other cause of disease can also be present for sure. I will go quickly to the slide just to put in perspective that the global health of children and the global mortality on Earth is very important in terms of other causes like measles, malaria, TB. Don't forget RSV, who can be, the burden of RSV is up to nearly 200,000 deaths per year globally. In Belgium, there's no much deaths per year, but as you know, all of you, high morbidity and high intensive care admission rate each year during the RSV season. In Saint-Luc, we had in total for the whole COVID-19 period, 4 patients who were admitted to PICU, 2 with the pediatric inflammatory multisystem syndrome, and 2 teenagers, 2 girls, and 1 boy, also a teenager with respiratory symptoms requiring BiPAP, and 1 3-year-old child who was severely sick with spinal amyotrophy, who died with COVID, but also with supra-infection with Pseudomonas aeruginosa sepsis. So sick patient exists, but it's rare, and the only child who died in Saint-Luc and was had high comorbidities. Alors, the next part of my talk will be more about transmission. This is mainly one of the points was quite tricky to explain. Remember, in the beginning of the pandemic, like the 16th of March, when Emmanuel Macron gave a talk, a war talk about pandemic, we are in war, and he told in this speech that the children were the big motor of the epidemics. So after that, it was really difficult to manage, because the SARS-CoV-2 was considered like flu for many people and in the society. And but it was not actually proved by a number at that time, and neither by experience in China or Italy in the clinical and epidemiological experience. If you think about transmission, this is a nice figure, was built by the team in UDERF. We collaborated to a review paper with UDERF, CHU Liège, and UC Louvain about a review about transmission and children paper which has been submitted. Basically, when you see a child who got the virus, he got infected, he can be either asymptomatic and never develop symptoms, so we can call him healthy carrier. Then we have a child who can be pre-symptomatic and developing symptoms, mild or even more severe symptoms. And then the big question is, what about the transmission risk of the virus from a child to a child, from a child to an adult, being asymptomatic or being pre-symptomatic? Just to show you here, on the slide, you have a picture of RT-PCRs, which is the main diagnostics test for COVID-19. You can see the cycle threshold of the PCR, what we call CT. When the CT is low, it means that the viral load is high. Okay, so the virus quantity in the nasopharynx is high. The big thing now is when you can have a positive patient with a positive PCR, but with a low viral load, so high CT, And when we do correlation between the RT-PCR and the culture, we can see that in some cases we are not able to grow the virus. When you are above roughly 24 cycles, you are not able to culture the virus. So some patients that are diagnosed positive case, positive PCR doesn't mean they are infectious. It just means that we find some viral particle, and those viral particles can be dead actually. So while the role of pre-symptomatic patient is well established in terms of transmission, the role of asymptomatic patient is less clear, and we don't know really, even in adult, the real impact of healthy carrier in the dynamic of the epidemic. So what we know since a few months now is that, of course, children can get virus in the nasopharynx. And we know by different studies that they can have similar viral loads as adults. So the big issue, because when we have a paper on that, of course, the press is talking about it a lot, is that it's not, we don't have actually a clear correlation between viral load and the contagiousness. In other words, viral load is not the only factor to transmit the virus. Other factors such as symptoms, such as the cough, the other factors can contribute to the fact that the virus will be able to be transmitted, easily transmitted to another contact. In the paper from Arnaud Lullier from Geneva, you can see he got samples from 23 children and he measured viral load in those children, and he found similar viral load as in adult. And as I told you just before, you can see that there were a significant difference in terms of viral load when you compare cultivable virus, culture positive and culture negative in terms of viral load. In a more recent paper published in JAMA, this paper showed exactly the same data. On 145 patients, they compared patients less than 5 years old, 5 to 17, and more than 18. And they showed that less than 5 years old might have a higher viral load than other age group. One of the limits of this paper is that we don't know exactly the age group, and for example, the less than 6 months old or other age group are not detailed in the paper. So for sure, so the children can carry the virus, but in epidemiological study and household study do not show that they are the main vector of the pandemics. For sure, we don't understand everything about that, but it is what we see in the different studies related to that. I just give you this paper as a reference from Geneva again, where they look between the 10th of March to the 10th of April, all patients less than 16 years old in Geneva, and they found 40 of 4,300 patients were less than 16 years old, so representing 0.9% of them. And in this study, they realized that only 8% of household developed symptoms before the household contact. So in only 8%, children were the index case, in other words. So in many studies, the case, children are the minority of them to be the index case in household studies. And even their number of secondary cases are also lower in children than adults. Alors, for children, there is another issue about testing. As you may know, in July and then in the 14th of August, the criteria to test children change. First, for the less than 3 years old children, and then for the less than 6 years old. What is the rationale? But we realize that when you apply the COVID-19 case definition, you will have to test many children to find one positive one, because the overlap of the symptoms, classical symptoms of viral illness with COVID. So if I give you an example, if you have an adult with RSV, he will just get a runny nose and he will not get criteria for testing, but children with RSV will often develop fever, cough, and other signs requiring, according to the case definition, PCR testing. So for now, the criteria to get tested in less than 6-year children is to get, for sure, to have positive criteria to be tested, major or 1 major or 2 minor criteria as usual, but also requiring hospitalization or being in contact, close contact with fragile person in the household. So the strategy is more viable for primary care doctors and pediatricians who are testing children they would, at a large scale before those recommendations were established. We can discuss about it if you want after in the discussion. For sure, one of the big problem is the testing and the way of testing. As you know, nasopharyngeal testing, nasopharyngeal swab is a procedure that is not well tolerated for children. You can do once, but when you cannot perform twice. We had the experience in our hospital with children who were repeatedly tested prior to procedures such as anesthesia. So the future is probably to use saliva swab, but for the moment, the literature and the heterogeneity do not allow to do that as a clinical, on the clinical field. But for epidemiological studies, this technique of collecting saliva is already on the way, with promising comparison in some recent paper. Alors, what about school and collectivities? Can every child go back to school? What is the effect of reopening schools in June, and what can we expect for the coming years? Alors, there are a few patients who cannot go to school, who are not allowed to go to school. We don't advise them to go to school. It's always a discussion with the physician and with the specialist looking for this child. And I have no time to go into detail, but you can find the list on the COVID-19 on the Sciensano website on those links. It's very important to respect the well-being of children and always weight in the decision the benefits for children to be in collectivities, in school, in stage, etc. For sure, we don't know what will happen for this coming year school. In June, we didn't see any effect on the global epidemiologic curve after kindergarten and primary school reopened. But for sure, in some area, some children didn't go back to school. So we have to see now in real life with secondary school who opened as well, what will be the effect in the next coming weeks and months. So I will conclude because I think I'm already finished my time. Just to give you a few reference that with the task force, we launched a campaign about well-being in children, and you can find all the information on the website where we try to give all scientific data, but also reassuring data about children and COVID, and to give also the argument to make the child to put the child in the center, but also to not forget all the importance of development and well-being. And the next speaker will talk about that also later this morning. There is a few good reference about literature on this website. Don't forget the bubble by our colleagues from UK. In UDERF, the registrars, so the trainees in pediatrics, realize as well nice video about COVID and children, just to explain COVID to children, which is very interesting also to share. So in conclusion, we can say that children are less often infected than adults. They are less severely affected also than adults. They do not seem to be the major vector of the pandemics. However, they can get similar viral loads in the nasopharynx than adults, but we don't know exactly what is the consequence of this viral load in asymptomatic children. We have reassuring epidemiological and household studies data. It's very important when you have a patient who come into the hospital with a suspicion of COVID to open the mind and not forget other diagnoses. For sure, with school reopening, it's very important to continue the surveillance to better understand the transmission dynamic, and especially in secondary schools. And pilot projects are on the way to try to understand what will happen, probably with the intervention of saliva testing in those settings. We don't know exactly, you know that you have heard about those super spreaders in choir, etc. We don't know if there are what is the role of super spreaders in children, especially in young children. Probably we have more the probability to have this case in some high school or secondary school. And I will conclude to say that we have to not forget about children's well-being and rights in all political decisions concerning children. So I would like to first say that this work is always a collaborative work with all colleagues in the country, but also other partners, other infectious disease and epidemiologists, doctors, and all other actors. And here you can find, and you will get the PowerPoint, all the resources, the links to get more information about COVID and children. And for teachers, you have also a webinar that we have realized with the pediatric task force to give information for teachers, and it's also available on the website of the Flemish Ministry of Education. It will be soon on the French and German Ministry of Education. I thank you for your attention, and I would like to acknowledge and to thank all my colleagues at the Pediatric Task Force in Cienzano, who did tremendous work during the last few months. Thank you very much.
Thank you very much, Professor van der Linden, for your very interesting and informative presentation. To the audience, please submit your questions to the chat, please, on this topic, and we will answer them. We have received one question about, as you explained, the majority of children are asymptomatic Unfortunately for them, they also have a nice and a smooth course of disease. This may make them more susceptible or less susceptible of having the disease to begin with. Should this encourage us to be more vigilant when caring for these type of children for certain treatments like as airway management, or should we testing them routinely before we do airway management, for example? What is your opinion on that?
I think so. We are going into an era that we don't know yet. So we are coming to autumn and winter with other viruses who will come along, like RSV, like flu, like parainfluenza, etc. So for sure, children will come with clinical symptoms of viral illness. If we have to test all of them, it will be impossible. I think we will have to do surveillance of viral illness in admitted children with viral infection to know exactly what's going on with, is it RSV, is it COVID, is it whatever. I think we will have to take universal precaution for those children. And for anesthetists, I think that you already have you already use PPE and N95 mask to do your procedure. If you do an aerosolizing procedure, you will use anyway a material that will protect you against COVID, but also other viral agents. I don't know if I answered the question because I didn't hear very well the part of the question.
I think that was the answer to the question. Thank you. There is another question.
Hi. Hello, Dimitri. It's Thierry Pirot. Do you have an idea if we know the rate of false negative results for the PCR in children? We have some ideas in adults, but are there data in children?
Well, the sensitivity is between 50 to 70%. So it will really depend of when the timing of taking the PCR. And of course, those results, the interpretation of the result will depend of the prevalence of the disease. So systematic screening, it's not for me an option according to the current epidemiology.
Thank you.
Thank you very much.
Good morning, everybody. I'm Joris Fundlings from anesthesia here at Zol. I'm responsible for the pediatric anesthesia and also a member of the board of the BABA. I'm honored to introduce you to our next speaker. That's Thierry Pirot. He's anesthesiologist at UCL Saint-Luc. He's also there responsible for the pediatric anesthesia. He gives a lot of teaching courses in ultrasound for regional anesthesia in children and adults, also for vascular access in children. Besides that, he gives also a lot of training in anesthesia in Europe and in the Africa continent. So I give you the word, Thierry.
Thank you very much for this introduction. So my topics will go about anesthesia during this pandemic, and we already heard a lot of really interesting information in the first lecture. We knew from the start from Chinese and Italian data that children seem to be relatively protected from severe form of COVID-19. So as we heard in the first talk, they can be asymptomatic of have mild symptoms, respiratory or gastrointestinal symptoms. So we fear a little bit that these children became silent vectors. So the major goal of our COVID-19 protocol was to protect us, protect the caregivers, to keep the manpower okay for the pandemic, and also to protect by protecting us, protect other patients, adults and children. As we know, in the operating room, there are a lot of aerosol generating procedure, and in anesthesia, really a lot. We think about intubation, extubation, endotracheal aspiration, nasogastric tubing, mask ventilation, nebulization, but also CPR. Then there are some surgical procedure who create also aerosolization. We know that thoracic surgery, ENT surgery, oral surgery, tracheostomy, this is well known. Bronchoscopy is also well known. Gastroscopy maybe is a little bit less known, and which is not so well known and maybe still a debate is laparoscopy, because we insufflate CO2 in the abdominal cavity and could come out with some charge of a virus. So in some institutions, they used a filter system to exsufflate the abdomen of these patients. So we had to protect ourselves from aerosolization. A virus can be contained in a droplet, can be contained in gas cloud. So we have to protect ourselves and our environment in the operating room or sedation area. When a patient sneezes or cough, there is a peak exhalation that can be quite fast and go over a long distance. So once more, we thought maybe we have more risk with children because small children come to the OR not wearing masks. Sometimes they cry, sometimes they are agitated during induction, and we are really in close proximity of these small patients with mask induction of just taking care of them. So you know the usual protective personal protection that we used, specific dedicated mask, face shield, gown, and double gloves. Now, when taking care of children during anesthesia, it's a little bit special, and we try really to make children feel comfortable. We are used to smile to them. We are used to shake hands with parents to get a little bit their confidence. So from the beginning of the pandemic, we know that by introducing these protocols, we will have major changes to do. Parental presence, we will talk about it later. Inhalational anesthesia is the usual technique, so we don't have to place an IV catheter. Usually we are less aggressive with airway management, using mask anesthesia, using laryngeal mask because they cause less respiratory complications. We try not to expose the children to too many drugs like muscle relaxant because they can cause allergy or delay awakening or push us to use another drug to antagonize. And last, we try to limit the duration of their pain. So if they come with a fracture, if they come with an appendicitis, we try to give them a fast surgery. So a lot of these things will change with the pandemic and the protocol we will introduce. If you're an anesthesiologist, probably you received this recommendation we wrote for the BAPA. It came out in March this year. You can find it on the link here below, but there were a lot of recommendations from different countries, different societies, from France, USA, Canada, Europe. Every country did some recommendations. Most of the pediatric COVID-19 protocols were in fact adapted from adult protocols. And in this lecture, I'll try to show you and to think about if these protocols were child-friendly or even safe. Of course, they were safe to control the risk of contamination, but maybe they had some psychological effect on these children, even some medical effect on these children. Sometimes we have had to wait surgery because we used testing PCR results, even with the fast one. Sometimes we have to wait a few hours. And we have seen some appendicitis waiting for a few hours and maybe becoming a little bit more severe with peritonitis. Some therapy like nitrous oxide were stopped during the pandemic. So some comfort therapy were stopped. And what was the solution and the alternative if we don't give nitrous oxide in the war is it was giving anesthesia and maybe giving anesthesia, full anesthesia with endotracheal intubation. So we have to think about that. A lot of surgeries and elective surgeries were cancelled. We had to think about organ transplant because some children cannot wait for months to have this kind of surgery. Another thing, of course, and especially for adolescents, we had to do some small orthopedic surgery because during the pandemic, they came at the end of their bone growth period. So some small surgery correcting deformation of the limb, we had to do them quite rapidly. Maybe these protocols had also effects on anesthesiologists because we had to work in different environments. Maybe we have dedicated pediatric operating room and we had to go somewhere else because we had to go in a COVID-19 operating room. We had to use sometimes unfamiliar equipment, sometimes change the technique of induction. So this is important. The change was bigger than we thought in the beginning. And that's why we wrote also in the recommendation from the BAPA that simulation session would be really interesting. And also that we have to think about basic safety. All the changes we make have to be put in balance with safety or of a general anesthesia in a baby or a child. You see here the usual practice, small circuit, external circuit, small balloon close to the child, easy to use, normal intubation. And this is the setting we use in COVID-19 for COVID-19 anesthesia, a full equipment. We have to use bigger circuits so you can place 2 filters, one to the patient, one for the ventilator. And it was advised to use maybe a dedicated device to intubate, videolaryngoscopy, which is sometimes not really the best way to do in a small child. So all these protocols will have change and some variation looking at the institution you work with. It was a constant evolution depending on different factors. The equipment resource was a problem in the beginning. The testing strategy, we thought about this, and there were really changes sometimes every 2 days. And this was quite hard for every caregivers because we had to change our protocols really frequently. It was time and energy consuming. So which level of protection, how can we classify children? They can be really COVID-19, they can be suspected, and they can have an unknown status and coming for an emergency. It was difficult, maybe even more difficult than in adults, because we know that the symptoms are mild or absent. Reliability of the PCR, we just discussed it a few minutes ago. And of course, having a negative test sometimes was just the key to do like before, and having a negative test in the first peak of the pandemic is still a moment we have to think about and about the false negative. So even non-suspected children had specific recommendation and specific way to take care of them. So in my presentation, I will talk about preparing an operating room, preparing the child, the induction, the airway management, extubation, recovery, and some slides about lessons for the future. So when preparing an operating room, often we had to use a dedicated operating room and a dedicated entrance for the children. So a lot of anticipation was needed. And when we did a case in a COVID-19 room, we have to take in account that we need twice much time than usual, and maybe sometimes two times more caregivers. It was quite heavy to organize this everything. In the room, we have to have limited equipment inside the room because of contamination, limited number of caregivers in the room. So maybe usually we do some cases with 2 anesthesiologists. This time the backup was just outside the door and ready to come in if needed, but if not needed, stayed outside. We have to limit the movement in and out. So even our personal belongings, we had to place them in plastic bags, for example. If we are on duty, you have the emergency phone, you want to take it with you, you have to place it in a plastic bag, another side. Otherwise, you give it at one person outside the room. So avoiding increased aerosolization, we have to think about different things. The soda line, for example, we change it before surgery. So we are sure we don't have to change it during surgery. And during induction and awakening, we try not to use forced air warming device like Behringer because it increases aerosolization. So we will use more warming lamps above the child, and we use only the Behringer during surgery when everything is covered. The aura setting, a lot of debate about the pressure range in the operating room. Most of the recommendation advocate a negative pressure because positive pressure can increase the risk of dissemination in other rooms. Neutral pressure is an alternative if we cannot use the negative pressure. Now, it seems that ventilation is more important than pressure, and ventilation is the air renewal range, and you can ask your technician how much is your air renewal range in your operating room, and it should be around 12 to 15 cycles per hour. By doing this in 30 minutes, most of the particles in the air are gone after 30 minutes. And this gives us an idea. If you do airway management, intubation, the persons there are fully equipped with the maximal protection. And if somebody came in the room afterwards, like a surgeon, who is a little bit further from the patient, then he can enter the room, but maybe 30 minutes later. In our setting, of course, the surgeon were in the room and were fully equipped. It's most important maybe for cleaning team. Don't let the cleaning team come in the room immediately after the case. It's better to keep the door closed and leave the ventilation doing its work. And after 30 minutes, the cleaning team can come into the room. If you have some SAS, some airlock between the door and the opening of the operating room, it's an additional positive point. Now we have to prepare the child, and usually the parental presence was avoided because in the beginning, lack of equipment for the parents, increased risk of contamination. You could be contaminated not by the child, but by one of the parents. And because of the logistic way and to let the parents come in and then have somebody to take care of the parents to go out again. But probably there were psychological issues, and especially in young children. You see the usual setting here with the parents there, placing the child on the table and giving anesthesia. And this is the new setting. The child was taken care by people looking more like aliens than as doctors. Premedication, you have pharmacological premedication and psychological premedication. Probably it's interesting to use pharmacological premedication if parents are not present, but even if they are present, sometimes it's interesting in this pandemic to reduce behaviors that increase aerosolization, like crying, being agitated, and things like that. If you use premedication, pharmacological premedication, you try not to use the intranasal route, which can cause sneezing. Psychological premedication, and I'm happy to see the site of the UDEF here. In the beginning of the pandemic, we didn't have so much time to organize and to make books, to make videos and things like that. But probably we can be more effective if a second wave is really coming. What we did use is oral instruction, distraction, and usual things like that. So induction of anesthesia, intravenous induction was preferred. You have a shorter period of potential aerosolization. Inhalation and induction lasts for 30 seconds to 60 seconds. IV induction can go in a few seconds. It will allow a rapid sequence induction, not using mask ventilation. But there are some issues. If the child is really agitated, is crying, is moving a lot, when you try to place an IV catheter, then you increase the aerosolization. So maybe in this setting, a mask induction is better. But we try to use this setting and use premedication, EMLA cream, and do our best like this, or even have an IV placed before the entering into the OR. In neonates, we like to keep the respiratory drive during the beginning phase of the induction. This is sometimes not possible with IV induction. If you have a really fragile child with a cardiopathy, sometimes IV induction is a little bit too rapid and give you too rapidly a deep anesthesia with maybe hypotension. So IV induction in some children is maybe not the best thing to do. Inhalation anesthesia, if you have to do it, and most of the time it's because it's better than IV induction if there are agitation of things like that, you have to use lower fresh gas flow, a really good sealed mask, and try to keep spontaneous breathing because it gives you less aerosolization than manual ventilation. Airway management, once again, the classic protocol was adapted from adults, and IV rapid sequence induction, no ventilation, intubation with a cuff tube, and use a video laryngoscopy. Video laryngoscopy, the idea is to have a longer distance between the face of the child and your face. Now, probably this device is not used a lot by a lot of anesthesiologists in a normal setting. So this is using a device that you are not used to. There are some issues, especially in small children. If you use a rapid sequence induction, because of pre-oxygenation is difficult because they have a lower reserve of oxygen, there are more desaturation. And because you give a fixed amount of drugs to sleep, you have sometimes more hypotension. So an alternative is to do titration and to give a ventilation. What we call ventilation is a ventilation with really low pressure with a mask well sealed on the face of the child, and use a plastic cover. I like to use the plastic cover which come with the Bear Hugger neonate. You have a plastic cover, you can stick it on the thorax of the child. You can use it to cover the body of the child during the induction and then flip it over the face of the child when you need it, and we use it a lot during this pandemic. The video laryngoscopy, unfamiliar for most of anesthesiologists, especially in neonates and baby, and it doesn't allow nasotracheal intubation. So using a normal laryngoscope, often you have a rapid intubation and a high success for first pass of the tube in the trachea. So if you use a device to be a little bit further away from the face of the child, but you take 2 or 3 times more time, probably the benefit is really, really low. So important point, maybe if we have to a second wave of to take care for other children, of course we have to wear the full equipment. We have to avoid intubation without muscle relaxant. So we have to place the tube and there's no reaction on the child. We have to avoid leak. We don't test the leak. Sometimes we did test the leak around the tube or other leaks by listening and going close to the face of the child. We don't have to do this. We have to inflate the cuff of the tracheal tube and measure the pressure, and then look at our ventilator if the expiratory volume is close to the inspiratory volume, so we can have an idea of the leak. Don't do too much disconnection during surgery, and place this plastic drape above the child's head. You see here, for example, if you, in some cases, you use a laryngeal mask, you can place this cover. Using a laryngeal mask is often not creating a lot of cough and a reaction when you take it out deep. And so probably the idea of aerosolization and using a laryngeal mask is an option. We have to avoid some funny tools, and this was described in adults, to make a plastic intubation box. So if the patient had a big reaction, coughing on thing like that, all his droplets and gas cloud stays within the box, and the ends of the anesthesiologist is going on two small holes. This is effective to limit contamination, but you have to be sure that your intubation is fast and you don't increase risk. So this is the idea of keeping basic safety during application of these protocols. Now, extubation and during surgery, if you have to aspirate into the tube, the best way is to use a closed circuit endotracheal aspiration. This is usually used in ICU. If you have to aspirate in the pharynx or in the tube and you don't have this device, use the plastic cover to limit the aerosolization. You can use this plastic cover when doing extubation, and you have to use a technique or an anesthesia that limit the coughing during extubation. The debate, deep or awake extubation. If you do deep extubation, they don't cough when you take the tube out, but they can cough a little bit later, but they are more obstructive, and you can have sometimes more complication like laryngospasm. If you have a laryngospasm and you have to treat it or to re-intubate the child, you lose the benefit of deep extubation. So the balance between deep and awake extubation will depend on the age of the child. If he has an upper airway infection, if his stomach is empty, and the preference of the anesthesiologist. Take care for good analgesia, maybe light sedation, so that the child after extubation is quiet, doesn't have pain. So he will cry a little bit less, he will not be agitated, and he will be calm. This is also really important. For recovery, it was advised to use the operating room to do recovery. This room is well ventilated, usually in negative pressure. The doors remain closed 30 minutes at least after extubation, the same caregivers, but the same caregivers, operating room nurse, anesthesiologist, has to remain in the room. So this was time and manpower consuming. Otherwise, they can go in an isolated and separated place in recovery. Often there is no parental presence, but once more, when you wake up and you see people like this, you can only give smiling eyes. You cannot show your smile, but you do your best, but you have to think, what is the child seeing when he, for the first time, opens his eyes? So we like to give light sedation, using a clonidine maybe, and to keep the children really a short period on recovery. So last slides and lessons for the future. I think we all learned a lot about healthcare and hygiene. We are much more prepared if there is a second wave, or even taking care of other infection during anesthesia. We know the body check to look at sterility and placing the personal protection equipment. We should probably use more body check to look if we do something and everything is really sterile. And thinking about storing all our airway equipment, being really careful not to place our equipment which is soiled and place them everywhere. We have to place them in a dedicated place. Now, an important point is this procedure, we would create aerosolization. And if you look at this recent study, we are a little bit surprised to see that in fact tracheal intubation exposed the caregivers to much more transmission than mask ventilation or even non-invasive ventilation. So all this idea of every child with COVID-19 or suspected COVID-19 should be intubated, we have to think about that and to be critical, because maybe if you use laryngeal mask, if you do short procedure with the mask, with the plastic cover, with the full equipment, probably the risk is not so high. And problems of coughing after intubation are really aerosol generating procedure. If you use ventilation without intubation, of course, we are now using gel ventilation, low volume and low pressure. So these adult-oriented COVID-19 protocols, I think, were not really child-friendly, but we couldn't do much better in the beginning and with the data we had. There were some safety issue because we make a lot of changes in our protocol. We use unfamiliar equipment, so we should be critical about that. And psychological issue, we know that there are a lot of stress in children just before and after surgery. Probably was inevitable for the first peak, but we are much more prepared. We know a little bit more about COVID-19, and probably we can still protect ourselves very well, but change some small things if we have a second wave. We don't have data about the outcome of children. If you give anesthesia to a child who has COVID-19, what is his outcome after anesthesia, after surgery? We don't really know. There's limited data compared to adults. It seems to be better than adults, less complication, but we don't really know. So I thank you for your attention. I give you here my email address and some interesting readings, and I'm open for questions. Thank you.
So, good morning again. I didn't see any questions in the chat. So if you have any questions, you can write them down and we will discuss them here. One question was, do you recommend intubation for all patients or just for COVID positive tested patients?
During the pandemics, there was a period all children were not tested, so all children were intubated. This was probably excessive. And then we started with testing all children before surgery. And then we had an idea, yes, it's negative, we can do other things. When we started using mask anesthesia or laryngeal mask anesthesia, it was with different protective ways. So even a child with a negative test, the anesthesiologist had a shield, had gloves, and if the child was not intubated, the plastic cover was placed over his head during anesthesia and during extubation. So we did take some more precaution, even with negative test children, but intubation was for all children really in the first weeks, and then we changed a little.
very much, Thierry. I'm very pleased now to turn over to the next speaker, Dr. Jeff Willems. Dr. Jeff Willems is a pediatrician and a pediatric intensivist. He currently works at University Hospital of Ghent as a staff member of intensive care medicine, and he has a large expertise and experience on pediatric critical care aspects and specifically on children who are affected or suspected through COVID-19 infection. He will be sharing with us his excellent expertise about pediatric inflammatory multisystem syndrome and COVID-19 infection. Jeff, thank you very much for joining us today, and it's very good to have you here with us today. Please.
Okay, good morning. I hope you can all see my slides. Thanks for the introduction, and thank you for the opportunity to share the PICU experience related to coronavirus pandemic. I'll talk to you about the so-called pediatric inflammatory multisystem syndrome, and I'll try to reflect on the question whether this is indeed a new disease entity on the PICU. And I'll start with a case study. I'll talk to you about an 8-year-old boy with no significant medical history. His relatives, his family was in good health. There was no contact whatsoever with a patient with coronavirus infection. He presents on the 1st of May with high fever, and 3 days later he's admitted to the local hospital with fever. He's suspected for a bloodstream infection and started on IV antibiotics. He has severe abdominal pain and diarrhea, and he's had a GI workout with a CT scan. He has a marked neurologic picture with confusion and irritability, and they've even performed a lumbar puncture and an MRI scan to exclude neuropathy. And on day 3 of admission at his local hospital, he deteriorates very rapidly. He develops hypotension and multi-organ failure with anuria and cardiac failure. He's then referred to a tertiary PICU unit with profound shock. He has persisting high fever. He has a clinical picture which is reminiscent of a toxic shock syndrome, as we see in severe streptococcal disease, with flushing, with vasodilation, and with profound hypotension. But he's also in profound cardiac failure, and an echocardiography reveals severely impaired left ventricular function, so also a picture of myocarditis. Additional investigations are done. Laboratory reveals signs of inflammation with, of note, a lymphopenia of 700, elevated CRP of 348, and an elevated ferritin level. Besides that, there are signs of tissue hypoperfusion with acute kidney injury, creatinine of 3.5, hugely increased troponin levels, and a lactate level of 14.6. Actually, this child at that moment was at the brink of a cardiac arrest. With this clinical picture and the lab results, immediately the diagnosis was made of a pediatric inflammatory multisystem syndrome associated with SARS coronavirus infection, or so-called PIMS. Sometimes the TS is added. This stands for temporally associated with SARS infection. And actually, the child was referred with this diagnosis. And this is interesting. First of all, how do we treat the patient? Well, there is standard ABC treatment or shock treatment with fluid expansion, which we've done cautiously in view of the cardiac failure. He required high doses of vasoactive medication, was on adrenaline and a noradrenaline infusion, and was on respiratory support at the brink of intubation, actually. We treated him with antibiotics because toxic shock syndrome, streptococcal disease was in the differential diagnosis. And in view of the diagnosis of PIMS, he was treated with immunoglobulins and steroids. He was on thromboprophylaxis, and of course, all isolation measures were done. Now, how do we link this with SARS infection? The PCR was negative twice on nasopharyngeal aspirate in the referring hospital. The CT scan, which was done over there as well, was negative as well, so no signs of coronavirus infection. And the serology only reached us later, so this was confirmed afterwards that there was a link with coronavirus. A further cause, shock reversal occurred quickly. 3 hours after immunoglobulin therapy, lactate levels started to drop and we could decrease the catecholamine infusions. And actually in the course of 48 hours, his organ dysfunction healed completely. And even on the day 6 after admission, he was discharged home. And this is typical for this kind of picture. These children, they tend to go very quickly in a shock reversal, and they tend to have very short PICU admission duration. Now, I've told you about PIMS, and now I'll explain you why we were talking about this syndrome. Now, if you've never heard about this kind of patients, I presume that the word PIMS make you think about the aperitif later today, or maybe some chocolate earlier this morning. So what are we talking about? And then we have to go back into the time, because we all knew that, or we all thought that coronavirus infections in children were not a big issue. This is a very nice overview from 11 Chinese case series up to the end of March 2020. Altogether about 300 children with all positive PCRs. 1/3 of them was completely asymptomatic, and about half of them had minor symptoms as cough and fever. Now, only 6% of these children in China actually developed any oxygen needs, and only 3% of them required PICU admission. Nevertheless, 2 children died in these cohorts altogether. But the conclusion was that coronavirus infections have a mild disease course in children. And this was actually confirmed in the first reports from the pediatric intensive care units. This is an early report on COVID-related PICU admissions in the north of America, all between half of March and April the 3rd. Altogether, we talked about 48 children aged 4 to 16 years. And of note, over 80% of these children had significant comorbidities. What does this mean? We are talking about medically complex children with severe developmental delay, or being tracheotomized, or being severely immune compromised. The majority of them developed respiratory failure or required invasive mechanical ventilation. 1/4 of them developed multi-organ failure. But even in this very small cohort, the case fatality rate was very low, with a mortality rate of only 4%. So conclusion was PICU admission for coronavirus infected children is very infrequent and largely in a cohort with significant comorbidity. This is the next report of children admitted on the intensive care unit, international collaborative, which described 17 children up to the end of April. Again, 70% had severe comorbidities, but of note, in this cohort, we already see 4 children with what they call a myocarditis picture, and all of them had severe GI symptoms. But then things changed. A report from Italy reached us. An experience from Bergamo, as you know, the epicenter of the coronavirus epidemic in Italy, where they noted a 30-fold increase in the incidence in Kawasaki disease during the period of February the 18th till the end of April. Of note, these children were of older age, had more frequently cardiac failure, more frequently a shock syndrome, and were more frequently treated with steroid therapy, which is a second-tier treatment for Kawasaki disease if compared to the historical cohorts. 80% of these children had positive serology for coronavirus. Then a second warning came in the south of London, in the Evelina Children's Hospital. They had to admit a cluster of 8 patients at mid-April, all with the same clinical picture. They all had hyperinflammation, a clinical picture which reminded of streptococcal toxic shock syndrome. They had added to this some Kawasaki disease-like symptoms, and I will talk about this later. They all had profound circulatory failure. They all needed to be intubated, and 1 of 8 patients died after an intracranial bleed. So these were severe warnings, and in view of the epidemiologic situation, statements were issued by the Pediatric Critical Care Society in the United Kingdom to remind physicians of the existence of a novel presentation of a multisystem inflammatory disease. By that time, also in Belgium, we had admitted several patients with an identical clinical picture, of which the boy I presented was one. And the Belgian Pediatric COVID-19 Task Force issued also a statement warning physicians working in the field that this clinical picture was rising in incidence. Only 10 days later, the ECDC issued a detailed and comprehensive document describing the clinical picture based on, by that time, 150 patient reports. The conclusion was that overall, the incidence of this pediatric inflammatory multisystem syndrome was very low, but that the impact could be really high. Now, what are we talking about when we talk about pediatric inflammatory multisystemic syndrome? First of all, this was a name given to the disorder by the Royal College of Pediatrics and Child Health in the United Kingdom, and this is the case definition. So it's all about children with fever, with signs of inflammation, both clinically and in blood investigations, and with evidence of single or multi-organ dysfunction. These children tend to be in shock, have cardiac failure, can be in respiratory failure, kidney failure, GI or neurologic disorders. And they can have additional features. Additional features which can be rashes, which can be muscle ache. And the children we saw on our unit typically had extremely severe neck pain or limb pain, so myalgia. And this may include full or partial criteria for Kawasaki disease. Importantly, other microbial disease have to be excluded, including bacterial sepsis, off-note streptococcal shock syndromes, and infections associated with myocarditis, such as enterovirus. Of note, in this case definition, a direct link or proof for SARS coronavirus 2 infection was not needed. But usually at that time, serology was not yet performed. In retrospect, we know that serology is usually positive. So in view of a negative PCR and positive serology, a post-infectious phenomenon was presumed. Good. Recently, we have reports of how big this picture was and how these patients really look like. This is a comprehensive study of all the children admitted in the UK with criteria of PIMS-TS. And this is during the period of April the 1st till May the 10th. We're talking about 78 children. And at the peak of the pandemic, about 32 of these patients had to be admitted on the intensive care unit a week. They were predominantly male, 67%, and of note, 78% belonged to what they call ethnic minorities. All these patients present with fever, most of them with shock, with severe abdominal pain, vomiting, or diarrhea. They all invest. Most of them required inotropic support or mechanical ventilation. Most of them were treated with steroids and immunoglobulins. Of note, only 2 patients in this cohort died. So mortality is relatively low, especially if you compare this, for instance, with streptococcal toxic shock syndrome, where mortality rates are usually in the double figures. Now, what's very important or very nice on this paper is that they compared this cohort to a historic cohort with patients who share certain features with them. We're talking then about patients with Kawasaki disease shock syndrome, patients with toxic shock syndrome, with HLH or macrophageal activation syndrome. If you look historically at the previous 5 years, we see that in this whole group together, only 1 patient a week needs to be admitted on the pediatric intensive care unit. And now, during the coronavirus outbreak, we're talking about 10 to 30 patients a week. So that's very significant. Once again, what's the presentation? Fever, GI symptoms, shock, respiratory symptoms only in half of the patients, and many of them, but not all of them, show signs of Kawasaki disease. Now, to make it a bit more complicated, in the United States, they have encountered the same disease modality, but they have another case definition. They call it multisystem inflammatory syndrome, and the case definition over there is a bit more restrictive. It's the same disease. They talk about children with fever, with inflammation in the lab, with multi-organ failure, but they require a proven link to infection with coronavirus. And this means either a positive PCR, either a positive serology, either a proven contact with a household contact with proven coronavirus. But largely the patient population is identical as the one described in the UK. This is the result of a literature search done by one of our assistants, Levi Hoste, who has gone through all the papers published up to the end of August, and he found altogether about 1,000 patients reported with the same clinical picture. Of note, mortality rate 1.9%, very, very low. How many patients have we seen in Belgium with the same picture? We gather these data. It's Stéphane Magnot from the UCL who organizes this, who coordinates this, and he told me this week that in Belgium about 25 to 30 cases have been diagnosed so far. In our center, we had about 6 patients of them. The last one was last week only. Now, do we only see this picture in children, or is there any adult experience in this? It's so that viral sepsis was thought to be very important in the pathophysiology of severely ill adults, also in the beginning of the pandemic. And the pro-inflammatory state with elevated levels of TNF and certain cytokines provoking a cytokine storm, followed by immune depression, is thought to be crucial in the disease mechanism of severe COVID-19. Nevertheless, it's a different picture than what we see in children. And this is also thought to be an acute infectious phenomenon rather than a post-infectious phenomenon. Now, how do we approach this practically? And these were the guidelines we gave to the referring physicians. Obviously, we have to think about it. The disease modality has to be recognized. And very important is that a blood pressure needs to be measured regularly in patients at risk. Targeted diagnostics include lab investigations, including signs of inflammation with a white cell count and a formula, ferritin levels, coagulation check and D-dimers, and then also markers of a organ dysfunction, as you see here. Echocardiography needs to be done as soon as possible by experienced physicians. And we have to look at coronary arteries because they can be affected in Kawasaki-like disease. Very important, and I think one of our previous speakers already touched this. It's important not to develop tunnel vision. These children can have severe abdominal disorders or neurologic disorders, and we don't have to think it will be PIMS. It can be other issues. And we know cases of children with bad or perforated appendicitis, which were considered as COVID patients and were treated too late. We have to do PCRs and diagnostic related to COVID infection, of course. And very important when you think about that this patient can suffer PIMS, consultation with the multidisciplinary center needs to be done with a very low threshold because you need input from pediatric cardiologists, immunologists, and PICU staff. When pediatricians admit stable patients on their units, they need to install early warning systems because these children can deteriorate very, very rapidly. And once they deteriorate, they need urgent referral to a PICU via the regular mechanisms. Of note, these patients respond very well to immune modulatory medications as immunoglobulins and steroids, so they have to be administered early. PICU guidelines are available. For instance, the Pediatric Critical Care Society in the UK has issued critical care guidance. This is a terrible slide. I won't go through it in detail. And we touched actually most of the points over there. But very important is the multidisciplinary approach and the awareness that these patients can deteriorate very, very rapidly. Now let's talk a bit of Kawasaki, because at a certain time, this issue got a lot of media attention and they talked about Kawasaki disease. And so we have to think, is this a new disease identity, or is this just coronavirus, which has a tendency to increase the incidence of Kawasaki disease? I'll tell you a second story. It's about a girl 9 years of age who was admitted early April. She presented at the emergency department with, again, high fever, with muscle pain and abdominal pain. She had been on a skiing trip in Italy in the end of February. She appears generally unwell with a toxic appearance. And again, she's admitted at the local hospital for IV antibiotics. She has clinical features which are typical for Kawasaki disease, with palmar edema, with rashes, conjunctivitis, and abdominal pain. But then she develops hypotension and tachycardia, she needs fluid expansion, and she is referred to the PICU. Again, PCRs for coronavirus are negative twice, hemocultures are taken, echocardiography is actually normal with a hyperdynamic left ventricular function and normal coronary arteries. The lab shows results we've seen before with leukopenia, with elevated CRP and ferritin, and with, importantly, elevated troponins. So actually this girl, for us, fulfills criteria of Kawasaki disease. And I'll talk to you about this criteria later. In the differential diagnosis, we always have bloodstream infections and other rheumatologic disorders. And of note, she's a bit old for Kawasaki disease. She's treated for Kawasaki disease with immunoglobulins and high-dose aspirin. And in the further course, she shows rapid improvement after administration of immunoglobulins. This child is considered as a child with Kawasaki disease with shock. But afterwards, after we were aware of this new disease identity, PIMS, we checked her antibodies for coronavirus and actually they returned as positive. So we had to call the parents and tell them this was a COVID-related disease. These are clinical features of Kawasaki disease with rashes, conjunctivitis, with oral mucosal changes. This is what we call a raspberry tongue, with edema of the hands and with adenopathies. When these symptoms develop in the presence of high fever for more than 5 days, we talk about Kawasaki disease. So this is a typical pediatric disease with a clinical diagnosis, and it typically occurs in the age group of 1 to 5 years. So these patients with PIMS, is it Kawasaki disease that we see with a sort of shock syndrome, or is it something else? And this is open to debate. Lots of papers have been published. It's a lot about semantics. It's a lot about names they give to the disorder. What do we know already? We know that Kawasaki disease can be provoked by viral illness, and common coronaviruses are known to be associated with Kawasaki disease. We know that there is a seasonal variability. We know that certain areas see more Kawasaki disease, for instance, Japan, so genetic features are important in the pathophysiology. But we see that classical Kawasaki disease is actually not more frequent during the coronavirus outbreak. Now, there are some differences. First of all, the age. We've seen typical Kawasaki is typically before the age of 5. The children with PIMS are typically older, with a mean age of 8 to 10 years. We also see that about 10 times as often there is a clinical picture of shock and cardiac failure in children with PIMS if compared to Kawasaki disease. We see also that if we look at the lab results, that CRP levels and ferritin levels are much higher than in classical Kawasaki disease. Typically in Kawasaki disease, we see a thrombophilia up to 1 million per microliter, whilst we see a decreased platelet level in PIMS. There are already preliminary data about immunologic investigations, and we see that the cytokine profile, which we see in classical Kawasaki disease, is different as the one in PIMS. But I think in the next couple of months, we may expect a lot more about immunology and PIMS. So from my point of view, my conclusion would be that PIMS is indeed a new disease identity on the PICU. It might not be completely different, but it is definitely different. I'm at the end of my talk, and we have some take-home messages. First of all, SARS coronavirus 2 infections in children usually have a benign course, but that we knew already. Rarely, PIMS-TS occurs as a post-infectious complication, and it has a potentially life-threatening character. But timely recognition, a multidisciplinary approach, and the right immune modulatory therapy are crucial factors, and if we achieve this, prognosis is actually excellent. And the immunology behind PIMS-TS needs to be unraveled and will be unraveled soon to really demonstrate us that this is indeed a new disease identity. This final diagram is just to check whether you all are still awake. And these are my details, and I'm ready for any question.
Thank you very much, Dr. Willems, for your very comprehensive presentation. We will answer questions from the audience now, please. We have received a question about the fact that The presentation of COVID-19 and the course of disease is obviously quite different between children and adults. Do we have a sensible explanation for that?
That's the key question, of course, and probably it's all about immunology. We've already talked about the reasons why acute coronaviruses infections are different in children and in adults. What we know is that, for instance, innate immunity in children is the response is much higher. We know that the acute cytokine storm with cytokine levels of IL-1, IL-6, and tumor necrosis factor, that they have a lower response on that level. But exact immunology we don't know yet.
That's fair. Thank you.
Now, nevertheless, we talk about this with our adult colleagues regularly, and maybe some of the patients who were considered as acute viral sepsis may have features of post-infectious disease as well. And we know that some of the adult patients respond very well to steroid therapy, for instance. So there might be an overlap, and definitely this is open for discussion. And obviously there can't be an age cut until what time you talk about post-inflammation syndromes and acute inflammation syndromes. So there's it's a lot about semantics. How do you call a disease entity? Yeah.
Okay, thank you.
So now I have the honor to introduce the last speaker of this webinar. It's the one that needs the less introduction of all. It's Professor Emeritus Peter Adriaansens. He's a professor of child and adolescent psychiatry at the Catholic University of Leuven. He was also director of that department also for trauma care of children, use and neglect. He worked also as a family therapist in the Context Center for Martial and Family Therapy at the university. He has numerous publications that cover the field of child and trauma, parenting and family therapy. He's also very social active and is since 2004 collaborator of Sisters John de Vos in India, where he works with children that over there. And he was also for 10 years president of the Queen Mathilde Foundation for Vulnerable Children. And since 6 years now, he's president of the Child Poverty Fund of King Baudouin Foundation. He has also numerous awards received, already the first one in 1985, the Van Goethem Richard Foundation Award for his work on rehabilitation of burned, disfigured children. The last one was the prize of Foundation of Verhulst van Eekhoven for his influence on as a medical practitioner, combining scientific research and social involvement. I leave now the word to Professor Adriaansens. Professor Adriaansens.
Hello, can you hear me? Can you hear me?
Yeah. Okay. Good.
Okay.
Yeah. Can you share your screen?
Okay.
On the below on the screen. Yeah,
Is it okay?
yeah. Now we can see you.
Yes, can you hear me?
Yeah, perfectly, and see you also.
Okay,
You know, just share your presentation, maybe.
okay. Well, thank you. Thank you for the nice introduction. It was not necessary to go through all this. And thank you for the opportunity to participate as a child psychiatrist to your meeting. The world of anesthesiology is not unknown for me. I am the son of an anesthesiologist, but my father was very surprised that the son of a doctor for whom it was very important that his patients were sleeping, that his son wanted his patients to talk. So from my discipline's perspective, you might say that's obvious, that we are trying to draw attention to the psychological impact of the COVID-19 pandemic and the measures that have been taken. Those who struggle most with the measures that prohibit physical contact, impose social distancing, are of course children and adolescents.
Can I interrupt you, sir?
Yeah?
Just can you share your presentation?
Yeah.
Just on below on your screen, you can share.
Can you, I have no message to share.
Can you below, if you watch on your screen, share screen, and then open your presentation.
Now?
No. Not yet.
No? It worked.
You have your presentation open on your computer.
Yeah. Oh.
And then,
Hmm.
dan even in het Zoom-scherm duwen op share screen.
I try to restart.
No, don't see it. If you share your screen in Zoom, uw scherm gedeeld, in Zoom zelf.
Ja, in de Zoom zelf. En nu.
Eraan, share screen, het groen knopje normaal.
En nu? Werkt het nu?
Nee.
Oké, het voordeel is dat ik psychiater ben en dat de slides niet essentieel zijn. Oké, ik... En... Ja, ja, sorry. Ik zal het op de tekst houden.
Je hebt op uw computer uw presentatie openstaan.
Okay, we zullen. We can see. Sorry for that. I don't know. It worked this morning, so. But okay, so there's a lot of discussion on the impact of the measures on children's rights. Children have seen their lives completely transformed overnight. They have stopped going to school, stopped meeting up with their friends and their relatives, and their confinement is much more severe than that of adults. And these measures raise a lot of discussions, of concerns. Are they reasonable, or is there overacting? At this moment, in most European countries, children return to school, but they will find school a different place to when they left it, with masks, disinfectant, temperature checks, becoming a part of school day. And some schools are also splitting classes into small groups or bubbles. Reports from several countries in the past weeks have shown that there is a greater risk of child abuse within the homes, that the number of women seeking refuge in women's shelters has increased. But I think, or we think, that we have to remain critical for reports who warn for the disastrous impact, mental impact of the crisis on children. It's too early for such conclusions. We lack good research on that. There are a lot of opinions, and there are a lot of observations in small groups. But don't forget that there is often an intergenerational solidarity. In the Netherlands, for example, research says that 2/3 of the families discovered in COVID confinement that they are more connected than they thought before. The disruption of everyday life affects little ones as much as adults, and they also experience the same emotional side effects: irritability, restlessness, fear, the classic symptoms of stress triggered by uncertainty. Most children who are living in normal everyday lives, in a reasonable home, with space to move around and light, those who eat well and have contact with their teachers through technological tools, they are coping reasonably well with the situation, and any harmful effect will disappear as things improve. So concerns are there for those who were already vulnerable before because of poverty, violence, learning difficulties, children of psychiatric patients, of drug abusers, and so on. Recent reports, for example, refer to children living in lower income households who feel more anxious and stressed, consume less fresh fruit and vegetables, get less exercises, and are more exposed to tobacco smoke. But this is already the case under normal circumstances. This is not only COVID effect. Children from poor families tend to have a poorer health. And the problem is that uniform confinement measures have been designed, assuming that it would be easy for everyone, but it isn't. It must be once more, unfortunately, we must say once more, a call to put children's health and mental health first in healthcare, and to strengthen our global strategies of prevention, strengthen the general health condition, mental condition of youth. Children may be confined, but their rights are not. But I want to focus on another group. We don't talk a lot about them, but that group is us, health professionals, doctors and nurses. Our problems are related, and the problems of our families are related to exposure to the traumatic effect of caring for COVID patients. Don't forget that we in normal life, in ordinary life, that we usually combine several roles simultaneously. We are man, woman, husband, wife, father, mother, and both are employees. That's hectic at the best of times, and all the more so when our work and family system has to cope with the extra stress of this COVID crisis. While hospitals and care homes fight to save as many patients as possible, we are experiencing a reversal of normal logic. We came from a world full of faith in science, with medicine that was making explosive progress, and a population that was in good average health thanks to extensive prevention. And suddenly, all that no longer applies. We are all threatened by something invisible, the virus. Much about it still remains unknown. And in order to fight it, we are falling back on measures that seem 100 years old, keeping social distance, wearing masks, washing our hands. The effect is, among other things, that many professionals find themselves in inner reflection. We have become more introverted because we need to reinvent ourselves. Our worldview and the image of our discipline need to be adjusted. The fact that COVID confronts us intensively with death is a source of grief. But a misunderstood source of grief is that at the same time, we are intensely confronted with our limitations, with powerlessness. Only if we take that on board, we will be able to move on. We know that many of our colleagues in healthcare, after a period of being stressed by their COVID experiences and work, will bounce back and be able to pick up their lives. But right now, many of us are in the transition phase, and this translates into the impact of traumatic stress on our behavior and mood. We swing between moments of pessimism, sometimes sadness, moments when we accept that it is what it is, but also, let's not forget, the opposite move, moments our profession triggers great passion once more. I've been hearing this during these last few months from intensive care staff who say, I'm waking up again, I feel challenged again. Yes, this is my job, this is my passion. And we know that during stressful experiences, those swings between good and bad moments help our hyperactive limbic system to regain its balance with our cognitive skills. There is not only this shift in what was considered as normal in our work, there is also an underestimated impact on our teamwork. As a child psychiatrist, I'd like to draw attention to the interaction between being a team member, a staff member, and our own attachment style, which is largely a predisposing factor. Working in a group is highly influenced by what we learned in life about dealing with the style of others. We all work in teams, and in a team, you don't all choose each other. So you have to use your skills to be flexible with colleagues from various disciplines in strange conditions. So when stress is added on top of that, our flexibility is threatened. There are 3 types of attachment styles that can be acquired at birth. People with what we call a secure style feel easily comfortable in many situations. People with an anxious style need a lot of control to avoid this unpleasant feeling of discomfort. And people of an avoidant style try to keep control over situations by avoiding teamwork, they just do their own thing. People who tend to an anxious predisposition, or colleagues who belong to the other extreme in the attachment spectrum and are of the avoidant type, have more difficulties in achieving good cooperation in the current environment. And the same goes for an extra group people who we call disorganized, which refers to the only form of attachment style that is not innate, but acquired after birth and is a consequence of child abuse and neglect. But normally, growing up, we learn to readapt our style. But this is not the case for everyone, and especially stress can push back people to a more rigid style. The nature of our attachment style has a major impact on our relational skills, and especially when they are under stress. So anyone who, as a child or a young person, did not learn to deal flexibly with their predisposition, threatens in COVID times to be prone to traumatic stress syndrome, to burnout, or to be extremely difficult for colleagues. And the traumatic impact of our work and the way it activates our attachment style also makes itself known at home. The intensified attitude of inner reflection is revealed there in introverted persons, fathers, mothers. Children tell us about doctor parents who are taciturn, who literally have to relax mentally at home, but are unable to do so because they are immediately back on the computer, immediately reconnected with scientific literature or with the hospital. We meet stories of partners who are curt, prone to anger, or who easily become emotionally and overwhelmed. I encounter colleagues who are now seeing things which already made their professional or private lives more difficult, being amplified by the stress caused by COVID, who are now coming into contact with previous life experiences as a child, adolescent, adult, which made them vulnerable. And this is now all breaking through. So caring for the future of our professional life, caring for the relation with our colleagues and patients and with our family system sometimes also means recognizing these signals and accepting an outstretched hand in time so that help can be provided. Now, how can you help your family, your children through this time being a father doctor or a mother doctor? What is now so different? The international renowned researcher Robert Niemeyer says in the Journal of Loss and Trauma, name it and claim it. People often have a vague sense of anxiety or wordless suffering, and we can help them wrap language around that. We can help ourselves and our families by verbalizing how we are doing so that our children can better understand what's going on inside us. And the same goes for your team. Getting together and asking how everyone is doing today is simple, but effective, targeted help. But also be an active listener. The fact that social distancing means that you can't even hold each other, even if it's just to give someone a pat on the back, threatens to make us worse at supporting each other. So here too, talking is incredibly important so that we can keep in touch. And the same in true is at home. Hand out more compliments, be more ready to comment when something is nice, tasty, well said. The explosion of video chat and Zoom sessions certainly cater to this, and lots of kids stayed in touch with their grandparents like this during the lockdown. But don't just count on people saying that they are struggling. We must be active listeners, observers, talkers. Say what your gut feeling is. Talk to your child. You're so quiet today. Are you okay? Don't you miss your friends? And third point is be careful if you don't find relaxation after the COVID measures have been lifted. If you, staff, family members, continue to function under stress, that's a warning. As I already said, many will recover from this crisis, but not everyone. COVID stress tests how we fit together. And even those who can adapt will still come out a bit different. And that may be in a positive sense. During consultations, we encounter young people who are suddenly motivated to get back to school because they have missed it. But there are also young people who no longer want to go to school because they found online learning so much so much better, so much faster, or more painfully. They haven't missed their classmates. Classroom bullying was finally terminated by lockdown. We see colleagues who only after the acute phase have begun to experience all their grief for deaths that they feel they had to deal with coldly at the time, where the dead immediately had to be put in body bags before family could get there. We see colleagues who were the source of serious conflicts in their workplace, who were unable to let go of an authoritarian style, and whose lack of adaptive skills meant that they have now been totally derailed. Not only will rehabilitation be needed for the victims of COVID-19, but there will also be colleagues who need psychological rehabilitation to rebuild their resilience and relational skills. Finally, a word about our patients in these COVID times. We have to be sensitive for the fact that research that is available at this moment says that quite a lot of young people, about 30%, score for some characteristics of depression, anxiety, post-traumatic stress. They are sensitive for the negative messages in our society about the impact of COVID on their future. It's difficult to understand that so many politicians, but even experts, say that there will be a devastating impact on school careers of young people. Young people are listening to us, and they take home these dramatic measures. And of course, the actual measures of social distancing and so on are at odds with what normal adolescents require: autonomy and their own territory outside the family. In about 5% of adolescents, the mental problems are serious. So we have to be sensitive for signals of mental health disorder. Recent research in review in The Lancet confirms the psychological impact of the measures, but it also points out that the consequences are more limited if you communicate transparently about COVID-19, if you use a kind of COVID for Dummies language, and that is very important, if you communicate enough about the well-being of those for whom you are caring. Much more than is currently the case, people need to be reminded that they are making an effective contribution to protecting the great majority of the population. Applied to COVID-19, this means that we will reach more young people if we ask them to refrain from lockdown parties in order to protect their grandparents and to avoid putting their friends in hospital. They are more likely to do it than if you tell them that they need to take care of themselves. So let me end with the hopeful reflection that one thing about crisis is that it can galvanize creativity and commitment. A year ago, I published a book, Verbolgen Verbonden, which you can translate as Outreach Together, and it called on parents and educators to teach young people that life is unpredictable and complex, and that is the actual normality, that we no longer live in times of straightforward answers. For every decision by a minister, by a scientist, by a citizen, you can be sure that you'll find others who think that it is utterly wrong. So if you are young, how then can you discover what a wise decision is? How can you learn to formulate a correct own opinion? So we need to deal young people trump cards for their future, which will require flexibility. And barely a year after of the book, COVID provide terrible illustration of this, an unforeseen pandemic, which we have to fight by flexibly transforming our hospitals, by making healthcare less dependent on certain Asian countries, and by not giving each other a hug. Those who are flexible are better equipped for these times. And this is what we must teach our staff, what we must teach our kids. Embrace complexity. Don't be afraid of it. Accept the challenge to work with it in this future. Thank you for your attention, and sorry for the slides.
Thank you for this excellent speaking on our webinar. We're very pleased that you could join us. We didn't see any questions on the chat function. Just one question. Do you see already less expressed emotions by children because of adults are almost covered all the time with face shields?
Well, at least we see this influence of the attitude of adults to their kids. If kids feel that adults feel comfortable by the societal care, that adults are confident that the medical world is doing its best and is talking transparently about where they are at the actual moment, then kids are in reality doing very fine. So we must, as has been said by colleague van der Linden, that we must be careful for tunnel vision. We must be aware that the children who are today children of great concern already were in that condition before COVID. Perhaps the sensibility of our society for the condition of children at this moment is an opportunity to stimulate government to invest in pediatrics, to invest in prevention. But it is not fair to tell children today that it is only because of COVID that they get in trouble.
Okay, thank you very much. I will give the word to my colleague for the closing word.
So with all of that said, I think we now have answered some questions. And I know that we only got a small fraction of all your questions. So if your question did not get answered though, or if questions arise after this broadcast, or if you have any suggestions or remarks to improve the quality of our activities, please, you can send those to the info email of BAPA. We will pass them to the appropriate subject matter expert. Finally, yet importantly, I want to thank all the speakers for their time and effort in sharing their experience with us today, and everybody for listening and participating with us. We enjoy putting this webinar on, and I hope you gain some valuable information from it. Please be aware that this entire webinar will be available on the website of BAPA. So you can go back to that and you can refer to them when it's convenient to you. Please use that. We look forward to your further comments, and we look forward to you joining us with the next congresses of BAPA. We can move on to the General Assembly of BAPA that is accessible to the BAPA members through the same exchange link. Thank you so much for being with us today. This is Nadia Najafi saying goodbye for the day.